Assalamu alaikum. Today I'm going to read atypical clinical case number 25, that is a 7-year-old boy with abdominal pain, wheeze and a rash. This case describes a 7-year-old asthmatic boy who presents with abdominal pain, vomiting, wheeze and a widespread rash following a Christmas party. Despite receiving initial treatment with oxygen salbutamol nebulizer and oral chlorpheniramine, his symptoms persist with ongoing respiratory distress, pale appearance and a urticaria. The scenario points towards an acute allergic reaction, likely anaphylaxis, which is a medical emergency requiring prompt recognition and treatment. The diagnostic criteria for anaphylaxis are based on three main factors. First, the reaction must have a sudden onset with rapid progression of symptoms. In this boy, the abdominal pain, vomiting, wheeze, and rash occurred shortly after exposure to an unknown trigger. Second, there must be life threatening compromise of airway, breathing, or circulation. In this child, the respiratory of 28 per minute, oxygen saturation of 92%, and breathlessness with widespread wheeze clearly indicate respiratory compromise. Finally, skin or mucosal changes are another key diagnostic feature, and the widespread urticaria seen here confirms the systemic nature of the reaction. It's important to note that while the presence of a rash or mucosal changes supports the diagnosis, these may be absent in some cases of anaphylaxis, making the systemic compromise even more critical for recognition. What distinguishes anaphylaxis from other allergic or respiratory conditions is its systemic nature. Unlike isolated asthma or simple allergic reactions, anaphylaxis has the potential to cause rapid and severe airway obstruction, respiratory failure, or shock. This underscores the importance of early recognition and immediate intervention to prevent life threatening outcomes. In terms of treatment, the priority is to administer intramuscular adrenaline, which is the first line treatment for anaphylaxis. Adrenaline is essential because it directly counteracts the effects of the allergic reaction. It causes vasoconstriction, which reduces swelling, prevents further airway obstruction, and maintains blood pressure to avoid shock. Additionally, adrenaline relaxes the smooth muscle in the airway, helping to relieve the wheeze and improve breathing, and also inhibits further release of inflammatory mediators like histamine from mast cells and basophils, preventing the reaction from worsening. The intramuscular route is preferred in this situation because it is safe, effective, and easy administered. Adrenaline given via the IM route is absorbed quickly and reduces the risk of complications. In contrast, intravenous adrenaline is reserved for cardiac arrest or care requiring intensive monitoring due to the higher risk of side effects like arrhythmias. Other treatments such as IV hydrocortisone or oral prednisolone are helpful in controlling the inflammatory cascade but act too slowly to be effective in the acute phase. These are given after adrenaline. Similarly, nebulized salbutamol or ipratropium may help relieve wheezing, but they address only the respiratory symptoms and not the systemic allergic reaction, making them secondary to adrenaline. In terms of investigations, the most helpful blood test in this scenario is mast cell tryptase. Tryptase is a biomarker released during mast cell activation in anaphylaxis. Measuring its levels can confirm the diagnosis, especially when the clinical picture is unclear or the trigger is unknown. The NICE guideline recommend taking the first sample as soon as possible after the reaction, followed by a second sample 1 to 2 hours later or no later than 4 hours. This ensures accurate detection of elevated levels. It is important to consider the broader management of this child after the acute phase. Hospital admission is necessary to monitor for a potential biphasic reaction where symptoms recur hours or even days after the initial event. The risk necessitates careful observation for at least 12 to 24 hours. Once the child is stable, follow-up is crucial. A referral to a pediatric allergist is needed to identify the specific allergens responsible, provide education for the family, and prescribe an adrenaline auto-injector such as EpiPen. The family must be trained in how and when to use it, as early administration of adrenaline in future episodes can be life-saving. Additionally, this case highlights a common scenario in children where food allergens like nuts are often first encountered at shared events such as Christmas parties. This delayed exposure, often due to avoidance during early childhood, increases the risk of allergic reactions because tolerance to the allergen has not developed. Educating families about allergen exposure and recognizing early signs of anaphylaxis is vital in preventing severe reactions. In summary, anaphylaxis requires prompt recognition and immediate treatment with IM adrenaline to address the life threatening systemic effects. Supportive treatments, investigations, and follow up care are essential to prevent recurrence and manage the child's long term safety. By acting quickly and ensuring comprehensive follow up, the risk of complications can be minimized. Here is the first question asked in this case is that which of the following would be the next most appropriate treatment? Select one answer only. Let's rule out one by one. First option is IV adrenaline. IV adrenaline is not the correct choice in this case. IV adrenaline is typically reserved for cardiac arrest or cases where IM adrenaline has failed and anaphylaxis is refractory to initial treatment. IV adrenaline carries a higher risk of complications, including arrhythmias, and should only be administered by experienced clinicians in a monitored setting. Next option is intravenous chlorpheniramine. IV chlorpheniramine is not the preferred treatment at this stage. While antihistamines help relieve urticaria and itching, they do not treat the underlying life-threatening symptoms of anaphylaxis, such as airway swelling and cardiovascular compromise. Chlorpheniramine has already been given orally in this case, and there is no immediate need to switch to IV administration. Next option is intravenous hydrocortisone. IV hydrocortisone is also not the priority in this situation. While corticosteroids help to reduce inflammation and may prevent biphasic reactions, they have a delayed onset of action and do not provide immediate relief from the life-threatening effects of anaphylaxis. Steroids are typically given after adrenaline has been administered and the patient is stabilized. Next option is nebulized ipratropium bromide. Nebulized ipratropium bromide can be helpful in cases of severe asthma exacerbation, particularly when there is poor response to beta agonist like salbutamol. However, in this scenario, the wheezing is likely due to anaphylaxis rather than a pure asthma exacerbation. The first priority is to address the systemic allergic reaction with adrenaline rather than focusing solely on bronchodilation. Next is oral prednisolone. Oral prednisolone is often used in asthma management and can be beneficial in allergic reactions to reduce inflammation. However, like IV hydrocortisone, it has a delayed onset of action and is not the first-line treatment for anaphylaxis. It may be considered as part of follow-up management but should not be used instead of IM adrenaline. Next is repeating the nebulized salbutamol. Repeating the nebulized salbutamol alone would not be the most effective treatment at this point. Although salbutamol can help relieve bronchospasm, it does not address the underlying cause of the reaction, which is systemic anaphylaxis. The priority is to administer adrenaline, which will not only help with respiratory symptoms but also address the cardiovascular and inflammatory aspects of anaphylaxis. So the most appropriate next step in treatment is intramuscular adrenaline. Anaphylaxis, as we already know, anaphylaxis is a severe life-threatening allergic reaction that involves airway, breathing, and circulation problems, along with the skin and mucosal involvement. The presence of respiratory distress, wheezing, and widespread urticaria confirms that this child meets the criteria for anaphylaxis. IM adrenaline is the first-line treatment because it rapidly reverses airway swelling, improves circulation, and reduces bronchospasm. It should be administered into the anterolateral thigh as soon as possible. Delay in administering adrenaline increases the risk of worsening symptoms and potential fatality. Here is the second question. Which of the following blood test is most likely to be helpful? Select one answer only. Let's rule out one by one. C1 esterase level. Measuring C1 esterase inhibitor levels is useful for diagnosing hereditary angioedema, which present with recurrent episodes of angioedema, often without urticaria. This child's presentation is more suggestive of an allergic reaction rather than hereditary angioedema, making this test unnecessary at this stage. Next option is C3 and C4 levels. C3 and C4 complement levels are used to assess immune system function and are sometimes measured in cases of suspected complement deficiencies or immune complex diseases. They are not relevant for diagnosing anaphylaxis. Next option is full blood count. A full blood count may provide general information about the patient's condition, such as signs of infection or anemia, but it is not helpful in confirming anaphylaxis. Next is serum histamine. Serum histamine levels can be elevated during an allergic reaction, but they peak and decline more rapidly than mast cell tryptase. This makes mast cell tryptase the preferred test for diagnosing anaphylaxis. So for the diagnostic confirmation, the most useful blood test is mast cell tryptase measurement. Mast cell tryptase is released into the bloodstream during an anaphylactic reaction and can help confirm the diagnosis. It is recommended to take an initial sample as soon as possible and a follow-up sample within 1 to 2 hours after the reaction, but no later than 4 hours. This is all about from this case. Thank you so much for watching. If you have any question, comment below, like, subscribe and share.